ورجعنا لكم تاني في حلقة جديدة من برنامجنا بودكاست بالسكر. مكملين في الحلقة بتاعتنا مع بروفيسور تيلر. Please, Professor, will you please introduce yourself to the people of Egypt?
Yes, I'm very pleased to be speaking to everyone in Egypt. I'm Roy Taylor. I'm a physician and scientist, and I spent much of my life looking after acute general medicine, but also diabetes and endocrinology. And increasingly, throughout the whole period, I've been trying to understand what happens to food after it's eaten, and leading on to trying to work on what was causing type 2 diabetes.
So, Professor, in the last episode, you were talking about what's the mechanism which led at the end to the direct trial. Okay, will you please continue?
Yes, these basic studies have shown that type 2 diabetes is reversible, that state of reversibility continues on a normal diet, and so this is the birth of remission, dietary remission. And people feel much better having done that. So the weight loss is much more achievable than doctors tend to imagine. When I first reported this work, the commonest response from doctors would be, no patient of mine would do that. Well, they were all wrong, because there's a substantial proportion, at least 40% of people who really hate their diabetes and would do anything reasonable to get rid of it. So we were well placed to embark upon a large randomized controlled trial in primary care, because in the UK, diabetes tends to be looked after by family doctors. So we needed to find out if this was practical to achieve remission in the real world.
Okay, remission means cure of diabetes. More or less.
I don't like using the word cure, because that tends to let people feel relaxed. And of course, if the weight increases, there is a 100% chance the diabetes will come back.
Okay.
So I would never say cure. So it's always remission.
Okay. So, that trial, how many people were in that trial?
For that trial, we powered it to assume that we would get about 22% of people in remission, and we recruited 300 people, 298 people. Half of those exactly continue to have best management of their diabetes according to NICE guidelines, NHS guidelines. The other half had the rapid weight loss process, followed by stepped food reintroduction, and then were seen every 3 months or so, just to encourage to continue. And it was a 2-year randomized controlled trial.
Okay. And what happened?
What happened was that the average weight loss after the use of the low-calorie diet was a gain, just over 15 kilograms. In fact, it was just over 16 kilograms. So this works in the real world. Recruitment was not a problem. We had lots of people who wanted to do this. And at the end of 1 year, now we'd follow them up after the initial weight loss, and there had been some weight regain, but the average weight loss was still around 10 kilograms. And at that time point, after 1 year, 46% were in remission. And I have to make clear that all the blood pressure drugs and all the anti-diabetic drugs were stopped on day 1. That caused doctors some problem when I explained the diet, and they were worried about it. But I showed them the data we had from the counterbalance study, which was our important second study, showing that stopping the glucose-lowering agents was consistent with a rapid fall in blood glucose over 7 days. So they were reassured about that. They were more worried about stopping the blood pressure tablets. Why would we want to do that? Well, in the counterpoint study, our first study, we found people suffered postural hypotension going onto the diet.
Postural hypertension is when your blood pressure falls when you stand up.
Yes.
Okay.
And the reason for that is almost certainly that in our daily life we take in quite a lot of salt, maybe 8 grams a day, but with the packet formula, people go down to 1.5 grams a day. So it's a sudden reduction of salt intake. And because of that, we can stop the blood pressure drugs, and the blood pressure gradually comes down. And one interesting point is that when we use this in primary care, stopping all the drugs, because some people are on 4 different agents, was a bit too much, and some had to be added back in. So now we have a very simple rule. We only drop 1 drug to stop blood pressure at the start of this process.
And then decrease as you go on.
And then decrease as necessary.
Okay.
So it's very simple, but here we touch on something that's very important for doctors, the process of deprescribing. Doctors are uncomfortable with stopping drugs.
Yes.
But this is a circumstance where we can stop drugs, save money, and achieve our goals far more simple.
Okay. So then after you did this, was diabetes did diabetes actually go away?
Yes. So
In how many percent?
after 1 year it was 46%. Now, of course, everyday life with infrequent follow-up. So they were only seen every 3 months. By 2 years, still 36%, over 1/3, had no diabetes on no drugs for the diabetes. So you see, this is enormously effective for clinical management and for economic reasons. And it's because of that the next phase opened up, because we now have an NHS, National Health Service, remission program, which is running on. And so we've moved from research studies into real life health service delivery of this method.
Okay. So now it has actively gone into the system, but as a spectator coming from outside, someone just having a look at this, the first thing that comes into my mind is you have to be very fat in order to achieve any result with this, because it's basically losing weight. What happens if you have a thin patient?
This is a really important point. One of the fascinating things about our data from Direct, where we recruited people of body mass index 28 up to 45. So it was that band.
Okay.
And we found that because we measured all the mechanisms, we studied people in my scanner, so we carried out the MRI procedures, we carried out metabolic tests. We were able to show that the mechanisms of what happened after weight loss were identical from BMI 28 to BMI 45. So I knew that I had had patients of normal BMI, but clear type 2 diabetes. And in my clinic, I had seen diabetes go away with the advised weight loss. So we then did a further study, which is called the Retune study, and we tested people with body mass index 21 to 27. And we found that diabetes went away, and the pathophysiology is identical.
Okay. May I stop you and ask you, is it possible that I can have a body mass index of 24, let's say, or 22, which means I'm pretty on the slim side, I'm pretty thinnish, okay, and have fat in my liver?
Yes, and I can illustrate that most potently by describing how this group of people of normal body mass index looked after the weight loss. Now, the BMI after the weight loss fell to 22. We matched them with controls who did not have type 2 diabetes, so there were weight-matched groups. And we looked at the abdominal fat.
Fat inside the belly.
In the belly.
Yes.
And we discovered that even though the weight loss had been sufficient to get rid of the fat inside the liver, these people still had excess fat inside the abdomen. Now, that itself isn't metabolically active. It's merely a store. It's just there. And so we come up with a very simple measurement. these people have got hidden fat that's causing their diabetes.
Mm-hmm.
So 2 points. One is, if a person has true type 2 diabetes, they have become too heavy for their own body.
Okay.
And I introduced the concept of the personal fat threshold.
Mm-hmm.
Our subjects in retune had quite a low threshold, and if they went above that, they got diabetes. Other people could go from a body mass index of 42 up to 45 and have diabetes, but coming down to 42, no diabetes.
Mm-hmm.
Now, this is such an important insight. Forget the epidemiological studies. They study populations. We don't learn how to manage individuals from these.
Mm-hmm.
The person sitting in front of you in clinic, if they have type 2 diabetes, has become too heavy for their own body. And that's very useful because you can explain that in terms of there is no stigma. It's not a thing to be ashamed of. It's just your genes that make you susceptible, but you can still take action effectively by losing weight and getting rid of this.
I remember you were, I was attending one of your lectures, and you were talking about, when the routine first came out, you were talking about these people in the study, and you went back to their school records to check their weight and height when they were in secondary school, and all of them, universally, they have all gained weight after that. And when you return them to their weight when they were like 18 years old, okay.
Yes. And even more potently, there is a better measure than BMI, and that is waist circumference. Very simple measurement. And it's such an important point because people sometimes find it awkward to measure around the person. No, you get the person to be standing up, and I would ask you to hold the inch tape and then ask you to turn around. And then I read off the reading. It's simple. And once you know that, it's no embarrassment, no difficulty to measure the waist circumference. And it is such a useful thing because, at least in the UK, everybody knows the size of trouser that they took when they were 21.
Yes.
And people say, no, I haven't put on weight. So what was your waist measurement when you were 21? And now it's increased. And that's where the fat is. It's hidden. So it's so important. And it's especially in men that it's so hidden. Women often have quite a lot of subcutaneous fat that's not metabolically active, but it's an indicator of fat elsewhere. But men can look really quite strong and slim, but have this expanded waist. And there's no good reason why waist circumference should increase during adult life. To be fully healthy, keep it steady.
Okay. So, this was really wonderful, these 2 episodes. I would like to ask you something totally out of the blue, but it's pretty related to this. Recently, all of these beauty clinics have been coming out, and they're all talking about local fat destruction, whether it's cryotherapy, mesotherapy, whatever therapy, okay? And basically, it's some form of physical destruction of abdominal fat, okay? And this fat, as we know from year 1 medicine, very long time ago, goes through the lymphatic system, okay, into the bloodstream, and is filtered into the liver. So basically, what I see as a clinician is that whenever I have someone who has recently done any of these procedures, his triglycerides, especially if he's diabetic, his triglycerides go into the thousands range, okay, hundreds range in millimoles, okay, and then I've seen quite a few cases of acute fatty liver, okay.
Yep.
And then when you're speaking to the people, for some reason, these beauticians have been telling them, well, this is the way to get rid of your body fat and to cure the liver from fat.
Yeah.
Okay. What would you like to say about this? I know it's totally out of your work, but
that's a mistaken concept, and it has actually been researched.
Really?
Even to the extent of people carrying out surgical removal of visceral fat, and it makes no difference metabolically. because the total amount of fat in the body is distributed according to how your genes dictate.
Okay.
It's the personal fat threshold all over. We are all polygenic individuals. We are
Many genes.
unique.
Yes.
So when you just take it away from one depot, the body will seamlessly adjust, and you won't get rid of fat from the liver doing that.
You actually may get more fat in the liver.
You may get more if you induce this destruction and triglyceride storm.
Yes.
And so that is potentially deleterious and so harmful. But we know that simply removing the visceral fat does not achieve what many people have predicted.
Okay. And my last question, because this is a real opportunity. Now, there is a myth. I know what it came from, okay? But it has an origin, and the origin has died, but the legend continues. That if you have fatty liver, you should never take a cholesterol-lowering drug because it is harmful for the liver.
No. The cholesterol-lowering drugs are entirely safe. Certainly in advanced cirrhosis, one wouldn't use them. But we're talking about an extremely common thing. And most people who are perceptibly heavy have too much fat in their liver. And it's entirely safe to just statins are remarkable drugs because they've been used so widely, and despite all the stories about them, the adverse effects are genuinely small. So I have no qualm at using statins with people with fatty liver.
Okay. And by this we conclude our episode. I am really thankful for you agreeing to come and join us, and hopefully I'll see you again at the next conference, and maybe we'll have something more to talk about.
It's been a great pleasure talking, and especially talking to people of Egypt. I very much enjoyed a visit to Cairo some years ago, so I hope this information has been interesting and helpful.
We'd love to have you back there, and thank you so much, sir.
My pleasure.
Thanks a lot. Thank you.